Hi all, thanks for joining. So we're going to talk about COVID-19 vaccine safety, dealing with adverse events, and there's the primary team. In fact, here's the largest team working on the project, so thank you to all, and we welcome more to join us. Framework is COVID-19 is important and vaccine safety is very important, and we need to either, if there are risks of those vaccines, we should identify them, but equally important, if there's a lack of risk, we want to assure the public that they're safe. So we're looking at what's so-called adverse events of special interest. Remember, these may not be adverse events, and I'll often use the word outcome. One approach to finding adverse events after you get a vaccine is to compare the rate of adverse events to a historical rate. So that's one approach. The European protocol mentions this and uses overall rates. So let's get the rates of adverse events like, say, anaphylaxis or a heart attack, an acute MI, in the population, and then compare that to what happens after you get vaccinated. The US Food and Drug Administration protocol does it on a database-specific rate. So they say, if I'm looking in a database for side effects that happen after vaccine, let me see what the rates were in the same database before that. In order to do this approach, we need a couple of steps. First and most important is phenotyping those outcomes, and I'll talk about that in a bit. And then we are working together to produce real rates that people can use, that is to produce the largest scale study of incidence rates of these outcomes that have been done before. Also being OHDSI, we want to understand the sensitivity of those estimates to the methods we use to estimate them. So I'll be talking about that. What I won't be talking about is some parallel efforts comparing different methods. So led by Martijn Schumi as part of the PLE-PLP work group, I mentioned one way to do it is to look at current rates and compare it to historical rates. Another way is to do a self-controlled case series. Another way is to compare cohorts with causal inference methods. And we'll be, as part of OHDSI, comparing those things, join PLP to work on that. Just to briefly note the two protocols, the European Medicines Agency has a protocol out called ACCESS, where they estimate baseline rates of these outcomes in the general population. They stratify by important population factors and the data source. They're going to be calculating incidence rates and providing 95% exact confidence intervals. So I highlighted that on this slide because I want to remind us that just the fact that someone says 95% exact confidence intervals should be a trigger for you to remember that, in fact, this only will account for the statistical error, which is very small in our large databases. And much more important is the systematic error, and that's the kind of thing that OHDSI is looking at. The EMA is looking at 23 outcomes. Some of them are named here: Guillain-Barré, acute disseminated encephalomyelitis, etc. And they picked two control events, colonic diverticulitis and hypertension, as controls to assess the effect. Here's one of the problems. If I look at my baseline rates for outcomes before COVID and I compare to vaccination, well, it confounders the fact that now with COVID here, people aren't going to their physician as often as they might have. So maybe the rates are dropping, not because they really dropped, but just because people aren't showing up at the doctor's office. So we want to control for that. The US Food and Drug Administration is going to compare incidence rates in the vaccinated persons to baseline rates from the same database. They have 4 claims data sources identified. They're using mostly something called Poisson Max SPRT, which is treating as a Poisson process, which just means that these things are kind of coming up randomly at low rates. And the algorithm, when you're looking at vaccination, data are accumulating as we go. We just started vaccinating. So we want to keep checking and see, is there a, say, acute myocardial infarction? Is AMI coming up now? Is it coming up now? Is it coming up now? As the months go by. Well, when you do that, you create, you have a wrong estimate because you keep checking the same hypothesis. You have a greater chance of calling it than you ought to. So the alpha spending plan adjusts for that. There's also a test margin, which you can look as a fudge factor. First thing, if something happens 1 in a billion times, the fact that you've raised it to 2 in a billion times, you'd still take that vaccine versus 1 in 100 versus 2 in 100. And it's also just a fudge factor to handle systematic error that we're going to be talking about. So they're going to look at pre-COVID and peri-COVID baseline rates and influenza rates. And then when they get a signal from this, they're going to do a more deep analysis, doing chart reviews and doing causal inference. The outcomes we're looking at as part of the FDA, myocardial infarction, anaphylaxis, appendicitis, Bell's palsy, DVT, DIC, cephalomyelitis, Guillain-Barré, 2 kinds of stroke, thrombocytopenia, myocarditis, narcolepsy, PE, and transverse myelitis. And so we'll be talking about some of the outcomes that we see with those things in a moment. So the first thing we're going to do is phenotype. Patrick Ryan is leading that with his team. The steps are first, of course, OHDSI's literature review, and looking at protocol definitions from the EMA, the FDA, and from other sources. Then we do our OHDSI knowledge engineering, looking at concept prevalence, using the Phoebe application, which helps you do knowledge engineering to define a cohort, and then cohort diagnostics to see what we ended up with. And then we do our formal evaluations using Phi-Valuator to estimate our sensitivity and specificity. And we just look at the face validity of the incidence rates we get. Does this make any sense? Recently, the FDA published their specific definitions of phenotypes, and we can compare to the phenotypes that we defined. We mostly see that the FDA is being a little more specific. We're being a little more sensitive. And there are some specific issues on a small number in both directions. So we're adjusting that. So the first OHDSI study that this team is doing, in addition, after phenotyping, Shintong Li from Oxford is leading, which is a descriptive epidemiology of these outcomes for COVID-19 vaccines. We're trying to produce the world's best estimate of the background incidence rates from 2017 to 19. We're using 8 claims databases, 5 EHR databases from 7 countries and 4 continents, so it should be generalizable. The estimates are stratified by age, sex, and database. So far, we have 300 million total person years of follow-up, so this is the largest study ever. The incidence, expressed as incidence rates per 100 person years, varies greatly for our outcomes. So our findings are, for example, 0.002 for transverse myelitis in one database to 1.4 for stroke in another database. So about a 1,000-fold range in incidence rates among these outcomes. And I'll show more results in a moment. Second study is the methods analysis I mentioned, which is Anna Astropolitz from Columbia, looking at study factors and how they affect incidence rates. So first is how the population affects it, exemplified in age, sex, and database, which we mentioned a moment ago. Next one is the target population. In an early draft, the FDA was looking at EHR databases and considered forcing of at least 1 visit in a year to ensure that an EHR database really had that person present, as opposed to someone who's named in the EHR database, maybe been seen 10 years ago, but they're not really present currently. And the question is, when we ensure that there's a visit that year, that changes the average severity of illness for patients in the cohort. So what effect does that have on the incidence rate estimation? Another factor is time at risk. If I look at the vaccines, I'm only for something like anaphylaxis. I only want anaphylaxis for that day and the day after. That's a 2-day time period. And it varies by outcome. Some of them 28 days, 42 days, 90 days, and 365 days. But when we estimate the baseline rates, we don't want to limit it to 2 days per person. We won't get any anaphylaxis. So there we want to look at the whole year, the whole set of years. So our time at risk is differing in the group we're measuring, that is the vaccinated group versus the baseline group, and what is the effect of that? The next effect is a large one, which is anchoring. You can either start your time at risk at some arbitrary date like January 1st, which measures the beginning of a period, or you could start at, for example, an event like a patient visit, a well visit, or a vaccination. The question, and the whether you anchor on an arbitrary date or a visit has a huge effect on the rate, especially if your time at risk is short. So the question at hand is, how does COVID-19 vaccination behave? When you get a influenza shot, for example, often you'll get it in the midst of another visit. You're seeing the doctor, and the doctor says, oh, while you're here, why don't you get a vaccination? And then if you have a side effect from that, is it from the visit, some other intervention you got, or is it from the vaccination itself? COVID-19, how much of that is going to be aligned with other visits, and how much is going to be as if it were an arbitrary date. And that still remains to be seen. COVID-19 is different from flu vaccination, and we don't actually know the answer yet. So we need to know at least the sensitivity to anchoring. And then, of course, we're going to look at things like are there secular trends in these incidence rates, 2017, 18, 19? Does season make a difference? COVID vaccination is starting in the winter. If an outcome happens more often in the winter, then the incidence rate is going to be boosted. We're going to be fooled by that. And also, as I mentioned earlier, how is COVID-19 what's its effect on healthcare utilization? So let's look at some results. First, let's look at I'm dividing the events by common, rare, and very rare. So we're looking at things like myocardial infarction is the first one. What you see are 5 plots for 5 outcomes. The x-axis is age group, starting from 0 going to 85 plus. So from left to right, we're going to older ages. The vertical axis is the incidence rate per 100 person years, but it's expressed on a log scale. So looking at acute MI, the scale is going from 0.0002 to 2. So that's a range of 10,000. So we're seeing estimates, depending on age group and database, from 0.002 to 2. Obviously, that's a gigantic effect on the incidence rate. Remember, when you're doing an experiment, you're often saying things like, oh, look at that, the hazard ratio or the odds ratio or the incidence rate ratio is 1.5. I'm worried about that. Well, here we have a ratio of 10,000. So now let's say we compare one database to another. If the age distribution differs only slightly, this 10,000 amplifier is going to make a huge difference in the incidence rate and is very important. The second thing that's plotted on these axes is the different databases, and those are the colors of the lines. And you see that on this scale, which is a huge scale, they seem very similar. But if you look more closely, the databases are differing by as much as about a factor of 10. So again, if you're looking for an incidence rate to go up by a factor of 1.4, well, what database you choose may affect it by a factor of 10, so you better be careful that you check within the same database. If I go to the less common diseases, actually you see that now this is a slightly different scale, so it looks expanded, but it's slightly from a different scale on the left. You're seeing less, we still see a strong age effect, although less prominent than the previous one, and we see amplification of the database effect. As we go to the very rare ones, actually the age effect starts appearing again, and we also still see the database effect. So both effects are important. So now let's go through a couple more hypotheses. How does sex, gender, male or female, affect it? Statistically significant at 1.13, but a relatively small effect. Part of the reason it's small is because we're bundling together the female and the male effect, and it's mostly men have more. Female has more transverse myelitis, male has more acute MI, myocarditis, and the 2 kinds of stroke. And those are the main ones there, which goes along with what we know ahead of time of the propensity for one or the other. But the effects even in the biggest one aren't that big. Now, what about anchoring? That is, with a 28 time at risk, what's the difference between if we look at someone at a random date like January, or an arbitrary date like January 1st, versus a random event during the year? And we see 1.6, that's aggregated over all outcomes in all databases. And you see a tight confidence interval around it. So anchoring has a large effect. If you take a shorter time at risk in some databases and some outcomes, it could be much bigger than 1.6. It can be as large as 10 and bigger. So anchoring and how vaccines are taken is going to be important. Time at risk based on an arbitrary date, we see 0.98. So if the time at risk is 2 days or 365 days, you see it has little effect. In other words, if you pick an arbitrary date, then whether you measure someone for 2 days or 365 days, if it's not anchored on a medical visit, we're okay. So this was a good, almost like a control negative. We weren't expecting an effect here. All of the above, by the way, we age adjusted and sex adjusted because we know the strong effect of that. And let me just mention the I-squared, which is the degree of heterogeneity among databases, et cetera, was very high, like 0.8, 0.9. And we did a random effects model for our meta-analysis, is what you do in this case, because we don't expect the databases to be the same. But it just also emphasizes the fact that the databases differ a lot. So in conclusion, Age effect is strong enough that you must adjust for it, period. Small differences in the age distribution can produce large effects. Anchoring is the second strongest thing. Yet we don't know yet how COVID-19 is going to behave, how people are going to get it, and it's going to differ from today versus 6 months from now. So how we anchor may differ in baseline rates. Databases differ beyond age and sex, so consider within database comparisons. Adjust for sex, it's a moderate effect, but it's present. And time at risk matters only when we anchor, and we've yet to look at year, season, and COVID-19. I want to thank everyone who ran analyses on their databases and contributed, and I welcome more to participate in the study.